Good morning, good afternoon, good evening, everyone. You're welcome to today's episode of Public Health in Real Life, a platform where we hope to highlight key global health issues, celebrate unsung heroes from the field, and inspire the next generation of public and global health practitioners. October 10th is often tagged as World Mental Health Day, a day to raise awareness on mental health and its importance in the global health discourse. The theme for this year's Mental Health Day from the World Federation of Mental Health is mental health in an unequal world. Ashwin, over to you to introduce our guest for today.
Thank you, Maimuna. Good morning, good afternoon, good evening to all our viewers around the globe. We are really pleased to have this conversation today, marking the World Mental Health Day tomorrow, October 10th, 2021. Uh, with us today is Dr. Howard Robinson. Dr. Robinson has more than 35 years of experience, professional experience providing mental health care to individuals, families, and groups. He has served as an educator and a trainer in the People's Republic of China, Israel, Taiwan, Rwanda, and Vietnam. Dr. Robinson specializes in trauma recovery and resiliency, and after completing postgraduate study of refugee trauma at Harvard Medical School in 2017, he focused his work in Rwanda as a trauma informed educational consultant who collaborates to promote culturally sensitive, integrated psychosocial mental health care. Dr. Robinson, welcome to the program.
Well, thank you so much. I'm absolutely delighted to be here and to have this opportunity to share my story and my work with your viewers, and to perhaps interested those who are in a place of making career choices to think about and to become excited in public service, and to begin to appreciate the incredible role of public health in our world today.
You perfectly captured the essence of this program and the objective of our channel, really to educate people around the globe about neglected public health issues and inspire the next generation of global public health leaders. With no further ado, jumping into the program, Dr. Robinson, you specialize in trauma recovery and resilience. Mental health as a discipline itself is often misunderstood because a number of aspects are not known. For example, the concept of complex development trauma. As an expert in this field, can you help our audience understand what is complex developmental trauma? What does it mean? And what are the implications, short, medium, and long term?
I'll begin in just talking a little, very briefly about the recently released 2020 report by the WHO, the World Health Organization, of their mental health atlas. And in their report, the statistics I'm going to give you come from the WHO, that in fact there are 1 billion people globally who have some form of mental health condition, and that there are an estimated 5% of adults who have depression, and that 1 in every 100 deaths are from suicide. And these conditions have certainly been exacerbated by COVID-19. What these staggering numbers still do not include are forms of is called traumatic stress that are pervasive, that affect generation after generation of families. They insinuate themselves into every domain of our biopsychosocial functioning. As examples, relationship with others that we have, our cognition, our memory, and even how we look at ourselves and the kind of self-regard that we have. And among the most toxic forms of traumatic stress is what we call complex developmental trauma. That, as you say, is not widely known among non-professionals whose primary role may be to advocate for government policies specific to mental health prevention, to suicide prevention, and to mental health as a universal human right. And this is why I want to bring knowledge about complex developmental trauma to the attention of our viewers today. Let me define, as you asked, what complex developmental trauma is. And there are two parts to the definition. The first being complex, and the second developmental. Complex because we are talking about experiences of traumatic stress that include multiple forms of trauma, of, of, of loss, of trauma from war, trauma related to economic and difficulties in livelihood and ethnic violence, that these multiple forms of trauma, including gender-based violence, interpersonal violence, and sexual assault, specifically in early childhood. And these multiple forms of trauma are mixed with the experiences of trauma being chronic, meaning that they just continue over time. And so this creates a particular challenge. And so there are layers upon layers of traumatic experiences that press on a person and put their actual biological organism, their built-in stress response systems, into overdrive, constantly activating their central nervous system to put them into internal states of survival, where all that the person can be focused on is the sense of threat that they have, that they experience is facing them. And when people are in a constant state of these survival states, they erode the actual health of the body, and they lead to negative and self-destructive coping strategies like addictions. Now, the term complex is linked with developmental because neuroscientists have now validated that these cumulative and chronic traumatic experiences actually change the structure and the function of the brain, and therefore directly affect our developmental process. The earlier that brain growth and its developing functions are impaired, the more severe the future consequences. Unfortunately, then, our bio, psycho, social development itself is at risk and will lead to poor developmental outcomes as the psychosocial consequences over time become more embedded and difficult to shift toward healthy functioning. Moreover, those who suffer from complex developmental trauma suffer invisibly. Their activated internal survival state is not readily visible to to others, and the emotional and physical behaviors of those with complex trauma are easily misinterpreted by teachers and by caretakers as children being personally disrespectful, personally rejecting, as being innately aggressive, as being uninterested, immature, or simply lazy. But when we shift perspective to that of a person with complex trauma, then teachers and caretakers can be taught to identify and interpret observable behaviors as symptoms, as signs of complex traumatic stress. And there is so much to learn here that changes the game, that will help everyone within a community, professional or non-professional, to respond to children and adolescents and later to adults in ways that will de-escalate the kind of what we call dysregulation of emotions and behaviors, and the kind of automatic responses that our body has. And so regulation is the word that we use to talk about being in a calm state. And that calm state, when it gets disrupted, we talk about as being dysregulated and escalates to higher and higher levels of lack of control for the individual. When we think of the necessary executive functions, and I may need to say more about what executive functions are, but these are necessary and important kinds of cognitive abilities that help us, for example, to plan and carry out goals through life. When we think of these very important functions, the short term, the medium term, and the long-term consequences are to evolving brain development and to learning itself. Because of complex developmental trauma, children, adolescents, and adults can be physically present in a space, but not emotionally in the room. And it bears repeating that complex developmental trauma affects all domains of our life functioning, our emotions and behaviors, our trust of others and our relationship with others, our capacity to have relationship and to relate to others, to have empathy, our capacity for memory and for problem solving, and the way that we, in fact, see ourselves among others. Now, I know that you also asked, I think, for what additional challenges
Yeah.
exist in working with underserved populations who
Yes.
might be experiencing the effects of complex developmental trauma and other mental health issues.
Right. And
So,
especially you can, so I just wanted to elaborate is you can possibly also share your experiences about refugees, because the word complex really applies to the population. And even though 1 billion people might be affected with mental health uh, conditions, the refugee population is a very unique class of people who really fit into that complex trauma, because it involves multiple aspects. And how does CDT specifically affect refugee population and other underserved populations?
thank you so much for raising this very, very important point. Uh, Refugees are people who cross national borders to avoid um, being killed, that there is threat to their life. So they are seeking a safe place, and refugee is a particular term to those who actually cross the border out of their own state. And of course, in the news today, we read more and more about the extraordinary millions of refugees uh, who are fleeing conflict situations. Uh, and um, this population, the reason that they are fleeing is because of experiences that they are having and have had of traumatic loss of parents being shot in front of them, of being separated from their families, of taking a voyage that is fraught with threats to life. It's no easy thing to walk from uh, Ecuador uh, to through the deserts and to try to find safety in, for example, the United States, and the same situation for refugees who are leaving Syria and are seeking safety. So they witness and they experience so many events of trauma and constant threat to their lives. And when we meet with refugees, their needs are so great just for security and safety that we often don't think about the kind of horror and traumatic experience that they have endured that are very difficult for them to even give words to and to communicate to someone else. And so this is a great challenge for refugees, and the um, the level of the level of traumatic stress and the level of exposure to violence uh, is uh, an easy recipe to develop these complex forms of traumatic stress. Maybe there's some other part of that that you would like me to pick up on.
No, that is excellent, and I think to Ashwin's point earlier is with that growing refugee population just due to conflicts and wars and instabilities across the globe, you have that rising refugee population. And you mentioned that usually the primary focus is on safety and security, forgetting the effect of complex developmental trauma. One of the things we want to highlight, as as somebody who is really vastly experienced in your area, you've had that interesting unique experience where you've worked in a resource rich setting, US, where you've trained, but you've also done projects in Rwanda, which is often considered is an example of a resource limited setting. We use this framework in global health. It started from maternal health, but it has really found its way into the global discourse, where we talk about the three stages of delay: delay in seeking care, delay in receiving care, and delay in seeking care, delay in reaching care, and delay in receiving care. So using that same framework in mental health, especially when we talk about the disparities in a resource rich and a resource limited settings, what do you think are some unique challenges that people face in, or barriers in, seeking mental health care, in reaching mental health care services, and in receiving mental health care services when they do get to a facility? It's a three-part question.
Yes, it's important for us to understand that uh, that refugee populations really exist within uh, within high-income countries, and unfortunately not enough countries that can actually support refugees, accept enough refugees. But um, you may easily find yourself working locally within your own local area with many groups of refugees. And oftentimes we are not aware of the many groups of migrating people, as well as refugees, that are in our own communities. So it takes awareness of these very vulnerable populations. And I know for myself, when I was with colleagues and studying with colleagues from around the world, um, who had much more experience working with refugee populations, um, I was, my eyes were opened to the extraordinary numbers of refugee groups that tend to settle together to support one another. So our work is not only international, our work is also within our own countries. So Rwanda is a country that has survived historical trauma, the trauma of colonialization, uh, and the trauma of warfare within their own country, and the trauma of genocide. In 1994, there were uh, 800,000 people who were killed in a very short period of time. Uh, and this is called the 1994 genocide uh, against the Tutsi. Um, and so the people of Rwanda are carrying what would easily qualify as complex developmental trauma. And I have seen in my work how this kind of experience is passed on from generation to generation, so that the children born to survivors uh, are now struggling with the effects of the traumatic experience on their parents or their caretakers, and oftentimes they don't have their biological family, and they often are raised in orphanages, uh, and um, and so and we have to understand as well that Rwanda is a country with large populations of who live in extreme poverty, and this is part of how we need to understand how mental health is connected with all other aspects of of our lives. So poverty is a main driver, in fact, of conditions that give rise to mental health conditions. Uh, Poverty means that there is food scarcity, that people don't have food, that the nutrition is not adequate. And Rwandan children have high rates of what is called stunting, where their brain does not grow, uh, and it affects the relationship that caretaker has to their children. These conditions uh, are known to heighten violence within the family, and gender-based violence, meaning that there are forms of their forms of attack on vulnerable girls and females and males of a sexual nature that are, again, the seeds for uh, the complex developmental trauma. And I work within a setting that is residential for 500 adolescents who are at the greatest risk of not succeeding in their lives and falling prey to the consequences of this kind of trauma. And what we are seeing are things as severe as, actually, I recently learned that there are many females that have somatic symptoms. That means that their uh, bodies don't function uh, for uh, for no where there is no medical reason to explain it. So we call that a somatic response. And these females literally cannot walk, cannot support their own weight, uh, and it is so disabling to them. Uh, Among the males who participate in active sports where there is physical contact with others, what is seen is that when there is physical contact, which occurs naturally if you're playing soccer, that as soon as there is physical contact, that there are violent fights that break out. And the harm that is done when violence is actually enacted on an other uh, is something that stays with a person. And so the consequences of these adolescents carrying these kinds of survival states and who can be triggered so easily to lose behavioral control, to uh, to lose their ability to think about consequences and to think about how their behaviors are going to affect and deeply affect another, um, are really impaired and blocked. So these are some quick examples of how this can play out. Now, this, to make clear, this particular residential village has incredible facilities. They have actually safe and secure uh, physical places to live. And in Rwanda, a home is not safe. Homes are subject to being washed out and for people to get killed within their fragile structures by mudslides. It's a very big problem. Uh, and there are great losses of populations due to this. And so for the first time in these adolescents' lives, they actually have a physical structure that's sturdy uh, and can create a safe space both physically and emotionally. And yet, even though adolescents are in a situation where there is safety, where there are sensitive staff. In fact, there are in each hut that houses a certain number of males and another hut, certain number of females. Every hut is based on the concept of a family and has what they call a female mama figure. And so they have someone who can be there for them, that they can develop a strong relationship with. And it's through developing relationship with an other that becomes trusting that they begin to heal. And despite all of these things, the effect of suffering from complex developmental trauma raises a lot of doubt in the moment, even in circumstances of real security and objective safety. There is still great doubt and fear that they carry with them that don't allow them to really take in uh, that where they are is safe. And even in the midst of these safe situations, they still enter states um, where they're not present, where they have no sense of the here and now, where they lose a sense of reality of what reality is in front of them, and they they turn within a kind of bubble within themselves that is a re-experiencing of past trauma. And the brain doesn't really know at that point that what they are experiencing internally is not the reality. And so they escalate to a point of what we call re experiencing a traumatic state. They lose a sense of that they're really with among their peers, that they have a mama right next to them, that they have teachers, that they're in a classroom, and they lose a sense of awareness of where they are and really experience of themselves as being in immediate threat when that threat is not objectively present in the moment. So the consequences are far reaching, and this is important for teachers and caretakers to understand. And it takes education to help caretakers and teachers in particular, and caretakers in particular, to understand this mindset, this way of functioning. And as I said, when you do, it really changes how um, teachers and caretakers respond, and they can respond with much more awareness and empathy, so that they can, without any specialized professional professional counseling experience, they can learn ways to create a sense of safety and to de-escalate and to calm uh, someone, because rather than think that they're behaving badly, when the perspective is that they their internal state has just gotten all mixed up and they have no way themselves to calm themselves down. They need people external to themselves to provide the calming environment. And when they do, and when they can re-establish the sense of safety around someone who's in this state, then their their internal uh, their regulation can return
Mhm.
to calmness. But when it does return, it still is at risk of being triggered more easily. So it's not like one returns without a need for continued uh, um, monitoring of what happens.
Yeah, that's really insightful. And you had touched on some of those challenges to people actually trying to seek care, even awareness of the fact that they are struggling, like just even understanding what complex developmental trauma and implications are. One thing you had mentioned previously was about the importance of having somebody external to oneself to help with that self-regulation or bringing back, centering, which really is then the responsibility of parents, caregivers, and specifically also mental health professionals. As you know, across the globe, there is a shortage of licensed mental health professionals, and that shortage is even more pronounced in resource limited settings. For example, in a country like Nigeria, there are only 200 trained psychiatrists or clinical psychologists for a population of about 200 million. And there's still data that doesn't necessarily capture all the different cadres of licensed professionals. So, how do you think we can address this shortage of licensed health professionals in the space to ensure that people have access to treatment?
Yes, first I want to comment on what kind of external, uh, who the external people are, and it's really a community. It requires um, communities to be um, the 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 mechanism and the people who can respond. So we talk about educating uh, all people in systems and community systems. Um, those those people who are actually in prison systems, those people who work in school systems, um, and so that they can, uh, as a community, take a caretaking stance and become more of a caring community. I also want to say that it is known that that not all people uh, are suffer long term from traumatic experience. That there are those who recover on their own. However, with this kind of uh, uh, trauma, it does require that help is needed. Um, and so, um, going back now to um, what maybe needs to happen within a state. Nigeria is such a, as you pointed out, such a great example. I did study with a very inspiring person when I was in the Harvard program, um, uh, Dr. Taiwo uh, Latif Sheikh, um, who is who taught me and helped me to understand how the systems within a country all need to be integrated and looked at. So there are challenges of distance between those who need care and where the care is centered. As you mentioned, there is a paucity of uh, standalone psychiatric hospitals. I think, in fact, there's maybe only one for the entire population. There are very few trained psychiatrists. So we need to think about um, ways to bridge distance and the uh, that bridge and to help people seek and receive services. Uh, Now there's potential in working in telehealth, in using, uh, in bringing providers immediately to those who have health conditions and mental health conditions, as we're doing now, because we're spanning right now space and we're closing that gap. And so this is a promising way to work. But what I was helped to understand is how important it is to work at all system levels. So it's important to engage the government uh, and to uh, engage and teach and pressure governments to provide funding and to make a commitment to mental health services. And then there are the challenges of how do you implement in the different circumstances? Are there transportation routes? How do you get pharmacological medicines to people? What is the quality of those medicines? What do we have to do to make them available? And this is a very complicated and sensitive piece of the work that requires and is helpful to have the 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 mental health um, the mental health community workers to develop a core of mental health community workers who are not professionals but who can be trained in psychological first aid, who the community recognizes is one of them, is someone they can trust, and this helps to create the kind of trust uh, that these vulnerable populations need to begin to even accept medications. That there are all sorts of cultural beliefs and historical experiences that tell them this is not to be trusted because African populations have been used, unfortunately, to pilot different drugs without any any care or consideration of the people themselves. They were just used like rats in a laboratory. You know, their human rights and who they were as people were just not uh, recognized or respected. So there are uh, many reasons, including uh, cultural beliefs and cultural beliefs mean that it's very uh, part ingrained within the worldview of people. Cultural beliefs are the lenses through which populations define what is good, what is bad, what is helpful, what is not helpful, what is dangerous, who you can trust, who you can't trust.
Absolutely.
And
Uh,
so these kinds of cultural beliefs are hard to displace. And uh, and to add, the cultural beliefs also include notions of stigma. And stigma in receiving mental health services is one of the greatest barriers for, even when there are treatments available, to people uh, not being willing to take and to engage with those treatments.
and Dr. Robinson, this also about the when you talk about the cultural differences, you have worked in multiple countries like People's Republic of China, Taiwan, Israel, Vietnam, and Rwanda as well. So, uh, could you highlight like an example of how an effective program had to be kind of like tailored for these different even though the treatment or the mode of application of the treatment might be the same that the but how did you tailor it to those civilizations?
Yes, thank you for that question, because they do have to be tailored, as you say, or adapted to the beliefs of the people in order for there to be acceptance of these kinds of things. Um, I I think that we see it now um, with um, well, things that are going through my head are outbreaks of uh, measles, which were under control globally, but have been recent outbreaks in the Democratic Republic of the Congo. And we know that measles spreads uh, incredibly, but there, there are cultural things so that parents who have measles don't want to be isolated from their children because they feel their responsibility to take care of their children, and thus the measles are imparted to their their children. Um, the there also were ways that I believe, I'm not thinking of the specific disease, but it will come to me, that it was found that the cultural need to uh, to bury uh, their their dead um, actually brought them in direct contact with the diseased person, so that by their being um, loyal and acting in a way that their culture informs them is what their role is, they were actually promoting the the outbreak and the further spread of the disease. And maybe one of you can tell me what that is, um, because it's just not in my mind at this point in time, you know. And we see it, unfortunately, today in the United States, in which belief systems have made certain populations just resistant to taking COVID vaccines that have been proven to be probably the safest vaccine ever created, um, because of some misguided belief or about uh, and and uh, and and clinging to information that is not reliable. Uh, and so reliable information has to be provided, and there need to be people within cultural systems who can be champions of uh, of working within the cultural systems of the community to find ways to to use uh, community traditions, and to find ways uh, to sort of to find ways to adapt to those traditions uh, uh, that they're aware of. So it takes real cultural understanding that the people who are live among the affected populations have the best understanding of. And again, I'm not sure if I answered all that you were looking for there.
Oh, you did answer the question, and like we previously mentioned about October 10th being World Health Mental Day, and it's it's really a day to raise awareness on global mental health issues and conditions, and ensure that government entities, as you had mentioned previously, join forces to ensure that people have access to mental health. The theme for this year from the World Federation of Mental Health talks about mental health in an unequal world. And you had highlighted some of those key issues about poverty, war and conflict, rising insecurity in different regions, further driving that wedge in the inequities and inequalities that we see, not just in healthcare overall, but specifically in mental health. So knowing all of those things and shedding light on those things, what inspires your work? What or who inspires your work?
Um, I want to say that I'll start with who inspires and has inspired my work, um, and actually what has most affected me uh, within the last 5 years. Um, and let me speak to that. Um, as I actually, from my work in Israel, I became much more aware of the impact of the Nazi Holocaust and its impact on the populations in Israel. And there's something that you gain, and that is absolutely needed to immerse yourself within a population, and to feel and to get an experiential sense of what populations actually experience. It's the kind of thing that you gain only by having opportunity to spend time with affected populations. And actually, what inspired me in that was what I recognized as, I mean, people who survived Holocaust and genocides. It brings in great relief. It brings really to the fore this uh, drive to survive, to persevere, to live, to look for hope, um, to find resources that support you, and to keep moving in the direction of rebuilding one's life, because is life is sacred and meaningful to them, despite the incredible experiences they've been through, and that um, because I haven't myself experienced the intensity and severity of the kinds of conditions that these survivors have endured. Um, I wasn't as I wasn't as aware of this this will, this built-in strength to move forward, uh, and to shape a future, uh, and to not get uh, hopefully lost in the past. And so I've taken inspiration from the people who have survived and the people who have uh, continued to have families and have children, and to find a way to rebuild their lives and to develop skills. This has been a tremendous inspiration to see how something that was so devastating uh, did not uh, was not something that kept them from uh, moving forward. Now, that's not to say that everybody can move forward at the same pace or in the same way. There's lots of support that's needed, uh, as we've discussed. Having social relationships and having people who can support and understand what you've gone through is very important, very meaningful. And so one of the people who's related to this, that has been a major inspiration, is my dear friend and colleague, um, who is Rwandan and who survived the genocide, and a couple of years after the genocide left the country, and rebuilt her life uh, here in the United States. Um, and she was a co-leader with me of a group of international people that I brought to Rwanda for understanding, getting a sense of what the population and the challenges are there. And um, she is someone. She is the quintessential representative to me of someone who has this um, amazing capacity to open herself up to whatever memories and experiences that she has, knowing that she will ultimately come out stronger and be able to integrate some of these experiences, or even able to kind of contain the confusion and recognize that there's more to understand. Uh, and uh, her ability to articulate and to talk about her own experience, her own story, which she does publicly because she's become a public advocate for genocide awareness and for human rights, uh, and has established her own. She's founded and executive director of an organization that is a genocide support network. Um, and that she continues to transform her experience to help others. Um,
Right.
and and this is very inspiring and helps me to continue when I get frustrated. uh, and uh, and it's very important to have those figures uh, in one's life.
Dr. Robinson, I think that was a really powerful response because I think that's what really puts you in the books of the distinguished, because your inspiration is driven by the bottom up. You drive your inspiration from the people who you serve, and that's
Yes,
really truly inspiring. And because you seem to be a person who has that clear compass, north pointing compass, and we would like to just to mark the day, which is about the World Mental Health Day. This year's theme is about mental health in an unequal world. So in one sentence, can you encapsulate maybe what uh, you would do to ensure mental health equity, or maybe you can also talk about an entity like the government should do. You can begin with yourself.
it's absolutely necessary that we bring awareness of the incredible need for mental health services, particularly to vulnerable populations, that uh, has nowhere uh, come close to being met. And so the awareness also has to be linked with um, a form of uh, pressure and advocacy that uh, the people themselves need to bring to their government. And the 171 nation states have signed a commitment with the uh, World Health Organization um, to to work on financing and meeting goals that have been planned uh, through the year 2030. And because they have actually signed and have expressed their governmental commitment to do this, the populations and the affected populations and their representatives um, can use this to apply pressure to governments to fulfill the promises that they have made, and um, and to make greater commitment to give resources and budget and services to promote uh, mental health. So that was a little bit more than
Oh,
one sentence, but I
well,
think it's about demanding transparency and accountability.
yes,
It's about accountability and
yes.
holding those who have the power to make decisions and to allocate budgets to be accountable.
Very well said, Dr. Robinson. In fact, that is like really see, due to mental health conditions, the world is losing out on almost $1 trillion economy, plus for every dollar that a country invests in mental health, the studies have proven that the ROI for every $1 is $5. Um, and so, like the people who are too much into this trade and not really looking into the public health realm, it's not like some kind of social good. Mental health is not only a social good,
Right.
but it is important for a nation. It's important for the building blocks of a nation. The people are, after all, the greatest asset for any nation. And anyway, this has been such a wonderful conversation, Dr. Robinson. I learned really a lot about what is complex developmental trauma and how it affects the neuro system and the somatic part of the body. And it's just really eye-opening to see like how to not only like recognize um, you know uh, recognize what people have went through in life, um, but we hope that through programs like this, there is more awareness spread. People get access to much needed mental health services. And thank you once again for this conversation. If people would like to contact you or follow you, do you have social media handles where people can either follow/contact you?
Yes, I do have a LinkedIn presence. I have a Twitter presence, and um, those are the social media. And I'm on Facebook, but uh, I don't like to use Facebook uh, for these the kinds of
No.
things. And so maybe I can, provide the information to you, and it could be added maybe as a document here. Um, you can really find me on LinkedIn through my name, and I think through uh, hashtag uh, hashtag HR3. Uh, and if you go to LinkedIn, then you can find my other contact information.
Cool.
Well, thank you so much once again, Dr. Howard Robinson. Is like Ashwin said, we've really been enlightened, especially on that topic of complex developmental trauma, which isn't necessarily known, even within the mental health space. For all of our audience, we thank you for your patience. We thank you for listening. Interestingly, we have an audience question or comment that I would like to just highlight before we close. It says, thank you, Howard and moderators, for focusing attention on this important need to repair what is being broken by bad human behavior.
Mhm.
The willful ignorance of the damage being done is a true war crime. So, quickly, is there anything you want to say to Mr. Dane Goodman?
I'm so moved by the wisdom of that observation, and it speaks to the need uh, to promote human rights,
Hmm.
uh,
Hmm.
and
Yeah.
the idea of repair. Repair is so important, and how do you create reconciliation as well with those who have murdered and those who are their were their victims, and we need this in the world.
Couldn't agree with you more, Dr. Robinson. Thank you, Ashwin, for co moderating this with me. And to anyone watching, please like and subscribe to our channel. And please give us feedback on any unsung heroes from the field or anyone like Dr. Robinson who is doing work in fields that are often neglected and would like to interview them on our channel. To everyone, please have a happy World Mental Health Day tomorrow. And remember, there is no health without mental health. Bye, everyone.